This slide's presentation deals with the Hedman et al. Article that was actually published in 1996. Even though 1996 seems like a long time ago, it was actually a time of a shift in how physical therapists chose to treat patients with neurological injury. And this is one of the seminal articles of the time that deals with the components of movement as well as the stages of movement.
When you think about the ability to move, it's composed of lots of different parts. And the picture in this slide shows a couple of guys running down a trail. Now, first of all, the act of running, they're using their arms, their legs, they have really good postural control, and they're not just running on a flat surface. This is trail running. You can see that it seems like it's a fairly technical trail. There's lots of rocks that they have to adjust to, and they're running through the woods, so there's going to be lots of roots, and they might be making sharp turns and so on and so forth. So this kind of activity requires a lot of motor control. Some of the components of movement that are necessary for even the simplest tasks are going to be just basic mobility. Does the patient have the ability to move volitionally? Another is force generation. Does the patient have sufficient strength to enable themselves to move? Does the patient have any muscle tone? And the following PowerPoint, the last PowerPoint in this series, we'll talk a little bit more about muscle tone and what's all involved there. Does the patient have sensory information that they can perceive? Are they in pain? Do they have sufficient speed? Do they have the endurance to be able to do the activity? I've had some patients who had COPD who couldn't walk more than 4 feet. They had everything they needed, but they sure didn't have the capability to move without their sats dropping because they lacked the endurance. Does the patient have good posture? Somebody who's forward flexed at the hips, which you often see in the elderly population, the geriatric population, typically are bent over forward. It's going to be a lot harder to maintain their balance with a forward flexed posture. Does the patient have balance and all that's involved in maintaining your balance? We'll talk about balance a little bit later in the semester. Does the patient have sufficient coordination to move? When they want their foot to go forward, does it always land in the place where they want it to go? Do they have the selective capacity to be able to choose what they want to do? And do they have adaptive capacity? Can they change what they're doing by will? And finally, do they have cognitive and psychosocial skills that will allow them to move? All of these are components of movements, any kind of movement, even the simplest. Now, the Hedman et al. Article breaks down movement into separate stages. First stage they consider are initial conditions, followed by preparation, initiation, execution, and termination. And the culmination of all of these stages results in the outcome of movement. And if there's a problem in any of these stages, then the outcome will be flawed or not normal. The first stage of movement that the article considers, they call initial conditions. This to me is very, very important. If you don't learn anything else from me this semester, please learn that posture is incredibly, incredibly important for proper movement and function. We're going to be looking at patient posture and working with patients in the lab. Absolutely, positively essential. The second part of the initial conditions, they consider the ability to interact with the environment. An example of a patient that might not have this ability is a patient in a coma or a vegetative state. We'll talk more about what these things are when we look at brain injury at the end of this course. And the final part about initial conditions to consider is the environmental context. What this means is it's going to be easier for a person to walk across a flat gym floor than it will be for them to walk down a hilly, rocky trail.
The next stage, movement preparation, is an important component of motor planning, but it's generally not observable. You're simply assessing whether or not an individual understands the instructions or the requirements of the task and can reflect the construct of movement preparation.
In this stage, the patient has to be able to identify the stimulus. For example, if you ask the patient to stand up and walk across the room and sit in the chair, they have to be able to identify what you want them to do. The next is response selection. This means that they have to be able to cognitively choose the correct response based on what you're asking them to do. And finally, the last step is called response programming, where they've selected the program that they want. Now they have to be able to do it, have it run in their brain. The next stage is called initiation. And in initiation, the patient population that immediately comes to mind are patients with Parkinson's disease. These patients really have a difficult time getting started. They also have difficulty with timing of movements that are required for, say, turning around to sit in the chair. Parkinson's patients really have a difficult time with this activity. They have a difficult time in their direction as well as their smoothness of movement. All of these components are important for the initiation of an activity.
The next stage of movement outlined in the Hedman et al. Article is known as execution. This is actually performing the movement, and performing the movement correctly by not that you got to the end result, but was the movement pattern similar to what you would see in a person who did not have neurological injury. Okay, this is important. We want to promote normal movement patterns. Just because a person is able to raise their arm over their head or go from sit to stand or walk across the room, are they doing it normally? Our job as therapists is to promote normal movement patterns. In doing this, when we do a task analysis, which is a subject that we'll get to here in a week or so, we're looking at amplitude of movement. Examples of patients who have difficulty with amplitude of movement would be Parkinson's patients, as well as Huntington's patients. Direction of movement can be difficult for lots of individuals. For example, if you ask a person who's been affected by a stroke to raise their arm over their head, they might succeed in raising their shoulder up, but the direction of their arm is definitely not going up. Another example for speed of movement, again, I think Parkinson's patients, and for smoothness of movement, I'm thinking anyone with a cerebellar injury is going to have difficulty with smoothness of movement. And again, when we get to the task analysis portion of the course next week, we'll talk a whole lot more about looking at the execution of movement.
Final stage of movement is going to be termination. Termination requires timing, stability, as well as accuracy. And again, any patient population could have difficulty with the termination of an activity. Parkinson's patients for sure, patients with cerebellar disorders, as well as patients that have had brain injuries and strokes. Overall, this information is useful because when you're identifying the movement problems that any particular patient has, you want to break down the movement into these different stages. Once you identify the kind of problem that they have and the stage that it occurs in, then you can design functional activities or any kind of treatment activity that would be aimed at solving the problem.